Thank you, Brian. Thank you for the invitation. I'm absolutely moved to be here, interact with patients. Can tell you it's very important for me as a physician to have this opportunity, and I'm looking forward for this interaction with CLL, CML, lymphoma patients, and Patients Association. I think we have a lot to learn together. And I want to correct you, I'm no longer a bone marrow transplantation physician. I'm just doing, I did training, but I'm just doing lymphoma and CLL. I'm a lymphoma and CLL patient. I'm sorry, physician. So I work here. This is a small center. Maybe we are now building a new facility. It's a more than 20-bed, 25-bed. It's unique in its kind, maybe in the world. Was founded by my grandfather. I'm third-generation hematologist, and as a hem-onc center, but just heme malignancies. We just treat here lymphomas, myelomas, and leukemias, acute and chronic. We do bone marrow transplantation. So I have I'm going to move forward. These are my disclosures, and I was asked to discuss this difficult topic. That's what do you do when you fail the two options that Florence just discussed. We are lucky in this time because we saw a change in the paradigm of treating heme malignancies, and CLL is one of them. 10 years ago only, we had the approval of ibrutinib, was really life-changing for so many people. Then we had the approval of venetoclax 2 years later, 2016, Acala in 2019, and zanubrutinib just last year. But now we're facing a problem that was addressed, is what we call the double exposed or double refractory, those who had received the two kind of agents, the BTK inhibitors and venetoclax. So, but the good news is we have new options that I'm going to discuss. Pirtobrutinib is a non-covalent BTK inhibitor that was approved in 2023, and CAR-Ts that were approved in March this year. So this is where we start with when we didn't have options. This is the life expectancy of patients who are double refractory, 5.5 months, and this is a real unmet need. And this was also addressed by the ERIC group that I just came from that meeting with Florence. They did a survey with 105 patients from 37 centers. So, and as you can see, this was mainly before the non-covalent era. The double refractory patients had the time to next treatment was only 5 months. So if you give them a treatment, will last only for 5 months, and the overall survival was 12 months.
Miguel, can I ask you to explain the difference between covalent and non-covalent inhibitors?
I'm going to show it in a graphic. Good. It's going to be easier.
Okay.
So here you go. These are the non-covalent. This was prepared for you.
Yeah.
We agree on this question. So as you can see, the covalent is the ibrutinib, and the second generation ibrutinib that's called Acala and zanubrutinib. They bond covalently to a cysteine residue, is C481S, but once the mutation, usually when they get resistant, the mutation occurs there where the molecule binds. So pirtobrutinib was designed to overcome this resistance, so it binds to a different pocket, as you can see here. And
I'm going to give people a little inside tip to understand if you ever read a science paper, and you'll see the term WT, which means wild type. Wild type is good. You want to be wild type because that's the type that's out in the wild. That's the natural form. And when it's no longer wild type, it's mutated, and that's bad. So when you see WT, that means it's okay, but when it's mutated, then sometimes the drugs don't work, other things don't go. So it's a little confusing because when you're first wild type, oh, that's going to be bad, it's wild, but it's actually good.
So this was a large trial, as you can see, with 282 CLL patients. Many of them were double exposed, double refractory with high risk molecular features. About half were P53, that this is a very feared mutation. When we have a patient with this mutation with any cancer, we as physicians get worried. And this is the response rate for patients who were double refractory. To the right, these were 100 patients. The response rate was about 80%. So this is very good news. And the median PFS, this is progression-free survival, the time that before they get a progression of the disease, was about 19 months, and 16 months for the double refractory. And this is the waterfall plot, where you can see this is the reduction in the lymph node masses. Most of the patients will have a significant, more than 50% reduction in the masses, and that's the curve of not overall survival. That's a curve of progression-free survival. I'm sorry. And then we also have a new option that's not been approved yet, and we are looking at this option with a lot of optimism. They call the BTK degraders. So this is a cartoon by Toby Eyre from England that really depicts the development of the BTK treatment. You have ibrutinib as the first generation, then we had the second generation, Acala and zanubrutinib. Then we got the non-covalent that we just saw, the pirtobrutinib, and we are ourselves conducting trials with nemtabrutinib. That might be another option. I'm not sure it's going to be approved because pirto is ahead of. And now we have the BTK degraders that are being basically developed by Nurix, that I believe is a sponsor of this meeting, and Beijing, that's also. And this data was presented at last EHA meeting in June 2024. This is the Nurix compound. Basically, what it does, it degrades the BTK, to make a long story short, through a E3 ligase by ubiquitination, but it doesn't. The BTK is the target of ibrutinib, so and it's important for the BCR signaling and CLL survival. That means the survival of the cancer cells. So if you degrade BTK, you get a response. And this is the trial. Is still not a very large number of patients. It's being done in CLL and other low-grade lymphomas. But again, a waterfall plot, you see 69% of responses. This is very encouraging for a heavily pretreated population, only 26 patients. We need to see further development of this molecule, but at least myself, I'm very optimistic. We're bringing a trial of a BTK degrader to our institution. And one of the good things, it works whether you have the wild type or if you have the mutation. So it's very good, because once you progressed on ibrutinib, you have a high likelihood of having a BTK mutation. And these are different mutations that doesn't matter the mutation you have. And the other compound is a Beijing compound. These are when we have phase 1 studies, usually it's letters and numbers. We don't have a name for the compound, as you can see there, BGB 16673. This was presented, it's called the Cadence study, was presented by Ricardo Parrondo from Mayo Clinic at the last EHA meeting. And almost the same number of patients, 49 patients. One here on the bottom, you see those who are, that most were exposed to BTK, and these are called, it's a new term, the triple refractory to covalent BTK, non-covalent BTK, and BCL2 or venetoclax. And here again, the response rate is about 70%, even if you are double refractory or if you have bad molecular risk factors as deletion 17p or P53 or complex karyotype. And then we have the bispecific antibodies that you know about, Brian. And this work basically, they are T-cell engagers. They engage the leukemia cell with a T-cell to kill the leukemia cells. And they've been approved already for other lymphomas, low-grade lymphomas, and diffuse large cell lymphomas. And now we have this trial that was presented by Arnon Katter that is still a small number of patients, 23 patients, but these are patients that have a median of 4 lines of therapy. This is a heavily pretreated population. Most of them were, again, double exposed or double refractory to ibrutinib or similar and venetoclax. And this is kind of the, I don't know if you're familiar with this term, CRS. You can get CRS up to maybe 50% of the patients will get CRS. It's a cytokine release syndrome. It's the kind of inflammation. You might get fever, you might get chills, hypotension, and you might require a IV drug to treat this syndrome that's called tocilizumab. And then the most recent approval has been the CAR T cells that they have been shown in different meetings by Tanya Siddiqui. This is the design of the trial. These are patients who are previously exposed to, all of them are previously exposed to BTK inhibitors. And there are different CAR Ts. This is called Lysocell. It's from Bristol. 2 different doses. Bridging is allowed. And many of them were double refractory or double exposed. You can see to the right, there's a population of 71 of the patients were double exposed out of 118 total number of patients. This is the primary endpoint of the study was CR. That was about 20% for both arms. But when you add all responses, goes up to 64%. And what's more important is undetectable minimal residual disease is about 60%. That's a very good figure for this heavily pretreated population. And this is the curves of progression-free survival or duration of response. You can see in the upper part, the patients who get the CR are the ones that are doing the best, as of course. But on the lower part, you are still controlling the disease for quite a bit. So to end the talk and make this long story short, how you sequence treatment in this disease, and if your first frontline option has been a BTK inhibitor, and you have progression on a BTK inhibitor, then the choice is easier. It's going to be venetoclax with rituximab. This was tested in a trial that was called Murano. If you get intolerance, my advice would be to change the BTK inhibitor. If the patient is in ibrutinib, you should change him to Acala or Sanu, or if the patient is in Acala, you should change him to Sanubrutinib. Keep the class of drug if there's a response, and the reason for changing is intolerance. And then you can sequence later with venetoclax plus rituximab or even obinutuzumab. So then you have the topic of my talk is the double exposed, double refractory would be the third line. I would always favor a clinical trial, but then we have the non-covalent BTK inhibitors. We'll discuss this later. We don't have access in Argentina and most of South America to non-covalent BTK inhibitors, so the way to access is through clinical trials, and we're going to stress the importance of having clinical trials in low and middle income countries, but that's a different discussion later. So clinical trials, non-covalent BTK inhibitors, and consider cellular therapies. CAR-T is approved, but also epcoritamab might be an upcoming option. And if the patient was treated first line, the approved first line limited therapy combination is venetoclax and obinutuzumab, now more recently venetoclax with ibrutinib in certain parts of the world. If the patient has a progression on therapy, should switch to BTK inhibitor, clearly. If the patient has progression after completion therapy, I would say if it has been more than 3 years, 36 months, you can retreat the patient with venetoclax and an anti-CD20 or a monoclonal antibody, either rituximab or obinutuzumab, or switch to BTK inhibitor. And if the problem has been intolerance, you can consider re-challenging the patient with venetoclax with adequate support, or switching to BTK inhibitor, and then the final path comes to the same 3 options: clinical trials, non-covalent BTK inhibitors, and cellular therapies, either CAR-Ts or bispecific. So as you can see, there's hope. So this is a picture of the Argentinian pampas. We have a flat, huge grassland. That's why we have such a good cattle and meat in Argentina. And welcome to receive you in Buenos Aires if you come. Thank you.
Thank you.